Welcome, everyone. We're just letting everyone into the Zoom room. So I want to just take a moment to thank everyone for joining us today. And I just want to remind everyone that this session is being recorded and will be shared with participants at a later date. And I'm assuming most of you know me, but for those of you who don't, I'm Mike Schreiner, your MPP for Guelph. And just want to say that I know the past year has been an incredibly challenging time for everyone in our community, but I want to just express deep gratitude and appreciation for everyone who's following the public health guidelines, who are staying home, but also finding ways to reach out and care for and check in for everyone in our community. And I know it's been a long haul, but encouraging everyone to stick with following the public health guidelines. I think we owe it, especially to our elders and all the frontline healthcare workers and all the essential workers who are providing the essential goods and services that we need. I know that many people have reached out to my office with questions about the COVID-19 vaccine rollout in Guelph. Everything from questions about what's the plan, what's the supply, when am I on the list, which is decided by the province, by the way, questions about the science of the vaccines and other questions. And so we decided to organize this session to be able to try to answer people's questions at once rather than a whole bunch of other one-off meetings, and also just to dispel any myths that might exist in the community. And so I'm hoping that today's session will answer your questions and give you a better understanding of the rollout plan in Guelph and in Wellington, Dufferin, and Guelph. And we're privileged today to be joined by our guest speaker, Dr. Nicola Mercer, who is a CEO and Medical Officer of Health at Wellington, Dufferin, Guelph Public Health. I'm going to introduce Dr. Mercer in a moment, but before I do, I want to just share a quick overview and lay some ground rules for today. So Dr. Mercer is going to provide a presentation on the overview of the vaccine rollout in our community and share more information about common misperceptions of the vaccine. And at the end of her presentation, we will have time for questions. And these questions can be directed to Dr. Mercer or to myself. And due to the large number of participants, we ask that you type your questions into the chat box, and our staff will go through the questions. And one of my staff members, Jackie De Silva, will articulate the question or ask the question to Dr. Mercer or myself. I really want to remind everyone to please be respectful of one another in the chat. And since the focus of this session is on the COVID-19 vaccine, I would really ask you to keep your questions to this topic. I know that many of you have other questions about other aspects of the COVID-19 response, but I'd really ask that you send those questions to my office, and my staff will put information how to contact my office in the chat box, and we'd be happy to answer those questions or to direct you to any supports that you might need, and or direct your question to the appropriate person or office. So please keep the questions focused on COVID-19 vaccines in Wellington, Dufferin, Guelph. Now I'd like to introduce Dr. Mercer, who I'm just really honored that Dr. Mercer is taking the time to join us today. As you might expect, she has an incredibly busy schedule. So Dr. Nicola Mercer was appointed as the Medical Officer of Health and CEO for Wellington, Dufferin, Guelph Public Health in 2007. And prior to becoming a public health physician, Dr. Mercer completed her fellowship in anesthesiology and served as the chief of the Department of Anesthesiology at the Guelph General Hospital. Dr. Mercer is past president of the Wellington County Medical Association and currently sits as a member of the University of Guelph Board of Trustees. Additionally, she has special graduate faculty status in the Department of Population Medicine at the University of Guelph. And having received her medical training, including her residency at the University of Toronto, Dr. Mercer also has received a Master's of Business Administration from Wilfrid Laurier University and a Master of Public Health from the University of Waterloo. And I just want to say on a personal note, Dr. Mercer, prior to the COVID pandemic, but especially during the COVID pandemic, has been just a very valuable resource for me to reach out to as MPP. And I just want, on a personal note, want to thank you for that, Dr. Mercer. And also just want to highlight that of all the public health officers across the province, Dr. Mercer has been a leader in many areas during this pandemic. We were the first to have a mask mandate, and also Wellington, Dufferin, Guelph is the first public health unit to receive and administer vaccines. And so, Dr. Mercer, I think on behalf of our community, just really want to thank you for your leadership prior to the pandemic, but especially during the pandemic. And so at this point, I'd like to turn it over to you to give a presentation, and then we'll answer questions.
Well, thank you very much, and thank you everyone for attending. One of the challenges with Zoom presentations is I don't get to see you. In fact, I'm looking at the slide right now, which seems to be showing a lot of red marks for some reason, which I'm not quite sure about, but anyways. So I have the pleasure of speaking to myself in a room right now. So I can't see your questions on the chat, and I'm hoping that as I go through this presentation, I will be able to answer a lot of your questions so that I've already covered them. And obviously we will take some specific questions at the end. So for those of you, if you happen to be a very educated person in the sciences and vaccines, you might find this chat a little disappointing because I've really tried to gear it for everyone, sort of the average person, trying to make sure that we bring everyone to the same level. It's important to me that there is sort of plain language around what is happening in terms of the pandemic, what's happening with the vaccine rollout, and the current plan as we know it today. So I'm just going to start, and let's just hope that we answer all your questions. So next slide, please. So we're going to talk a little bit about COVID-19 and what we see in WDG. A lot of this will be from our website. I also have the talk specifically about the COVID-19 vaccine, and I hopefully can answer your questions on that. And then the distribution of the vaccine, which I think is on everybody's mind right now. And then hopefully some myths that are commonly heard and we see on social media, and we can try and answer those questions for you. So next slide. So this is really what it has looked like locally. We have had over 4,000 cases confirmed to date. Most of those cases have resolved, thankfully, but you can still see that there's still a fairly large number that are still ongoing. We've had 70 people die in our area from the COVID vaccine, and we currently, as of the date that was yesterday, 10 people in hospital in our area as a result of COVID. So this has not been an insignificant burden. And I can tell you, though, that we have fared as a community quite a bit better than even some of our neighboring health units. So region of Waterloo has certainly had higher rates and higher numbers of deaths in their population than what we have. So it has been really a significant health episode locally. And I know that for some people, it hasn't maybe impacted your family, but for many people now, they know somebody who's had COVID, and many of us actually know if somebody's been hospitalized or has even died of COVID. Now, next slide, please. So this is what the pandemic looks like by cases. So you can see if we go back to the very beginning of the pandemic, and I think almost all of us can remember what it was like in March when all of a sudden the province closed down. And if you happen to be out of the country, I'm sure a lot of you, some of you might have even been there and know that you were told to come home. This is the time to come home. But you can see the first wave. We were scared. We didn't know what this meant. And almost all of those cases in the first wave were people in long-term care or retirement homes. And the reason for that was we were all at home. In fact, we even closed all our businesses at that time. So there was very little happening back in the end of March and April. And then we slowly started to open. Well, of course, we opened at a time of the summer. And so we were outside, people were practicing physical distancing. My mask order came into effect when we opened. So it was actually intentional on my part when we actually allowed our businesses to open. That's when the mask order started. And yeah, it wasn't popular at that time, but I think now we look back on it and probably all think, oh yeah, that was an easy thing to do, and it makes sense. Whereas at the time, it really didn't seem to make a lot of sense for a lot of people. But look at how we did all through the summer. Everything was great. School started. Everything is great for still a very long period of time until we get to the beginning of November. And locally, our cases began to climb. And as we got closer and closer to Christmas, and then certainly after Christmas, our cases have significantly climbed. And it's only been in the last 2 weeks since we instituted a much more rigorous lockdown in the province of Ontario that we've begun to see our case numbers finally come down. I get the privilege of knowing of what a lot of these cases are and what's behind them. And one of the things that I can say is that what we did see consistently time and again throughout the months of November and December was that people were gathering. And so it was easy for people to think, well, it's just my best friend and my, brother-in-law and sister in the basement. Nobody's going to know about it. And so we do find that a lot of what we have seen has been the result of people getting together, which is what people want to do. We want to get together and see our friends and family. So next slide.
And Dr. Mercer, I'm just going to quickly stop share and try it again just to see if we can get these red marks off the screen.
Okay, thanks.
Okay. That does seem to have worked.
Okay, so great. Yeah, so yeah, it was a little bit distracting having those red marks on the screen, so that's great. So next slide, please. So who has got COVID since the beginning of the pandemic has changed quite significantly. So very early on in the pandemic, it was almost exclusively those who are over the age of 80. Very, very much so. But especially since September and we opened up and as people got back to work, what we saw was increasing numbers of people in the age group, in particular 20 to 39, and the next age group 40 to 59 getting COVID. If you look at this, you'll see that the darker orange is what we call outbreak related cases, and the light orange is just individual cases in the community. So if you look at over 80, the majority of people over 80 who are getting COVID are those who live in congregate settings, long-term care retirement homes. If you look at our age group 20 to 39, we still have majority of those cases are actually just independent cases in the community. We do still, however, have a number of cases, and those would be related to workplace outbreaks, or potentially the University of Guelph outbreak would be an example, or individuals who work in long-term care retirement homes. And that would really be the case for those between the ages of 20 and 59. So majority of our cases are still individual community cases, but when we do have some significant outbreaks, such as ones that have been in the news like Cargill, then they do add to our outbreak-related cases. And these are rates per 100,000 by different age groups. Next slide. I really want to talk about this slide because this slide really says a lot that people don't always think about or understand. Everybody's scared of getting COVID. Everybody thinks that they have a high risk of getting COVID, but what we do know is that the risk is not spread equally. In fact, I can tell you, because I see who all the cases are, where we're seeing COVID. If we look outside of our long-term care retirement homes and outside of our hospitals, we are not seeing large numbers of cases in healthcare workers. We're not. Where we are seeing cases outside of long-term care retirement homes and hospitals is in some of our larger manufacturing plants, for example, and in other sometimes congregate settings like residences at universities. So it's not equal who gets it. Some people in our society are able to work remotely, for example, or have access to better PPE, or are able, even if they go into work, are able to separate from others in their workplace. We are not seeing and have not seen high numbers of cases within teachers, for example, which I think really is a reflection on how the school board has been able to protect them and to organize the classroom. But where people get COVID, this is what happens to them afterwards. So if we take a comparison group, a healthy 20-year-old, for example, and that would be in the top group, we use that as our comparison group. What we see very distinctly is that who gets hospitalized and who dies from COVID is not equal. And in fact, it's very disproportionate. So if you happen to be over the age of 30, your chance of being hospitalized are only twice the rate of a 20-year-old. Your chance of dying, though, is 4 times the rate of a 20-year-old. But look what happens as we get older. It's really quite exponential. So once you get past the age of, in particular, once you get past the age of 50, your chances of dying from COVID go up to 30 times higher than a 20-year-old. But look at when you're over the age of 65, 90 times, and then even more disproportionate by the time you get to age 75 or age 85. So in our society, those who are getting hospitalized if they get COVID and are dying from COVID are absolutely those who are the older members of our society. So healthy younger people and even unhealthy younger people do not have the risk that those who are what we call age-related risks. So if any of you who are on this call are over the age of 65, and in particular if you're over the age of 75, then you need to be really mindful that COVID for you is not the flu. It is very different. We know in the past that we've had, flu pandemics, and they do disproportionately impact our elderly people in our society, but not to this rate. 630 times chance higher of dying than a 20-year-old if you're over the age of 85. And we've absolutely seen that in terms of who dies. If you look at the American numbers, for example, they've had about 500,000 people die in the US. 80% of them have been over the age of 65. So yes, it is very disproportionate who is impacted by this disease. Next slide, please. So how do vaccines work? So I'm just going to provide a general level here, and then we'll get into a little bit more specifics. So vaccines, all vaccines work in the same way. Our bodies need to create antibodies or to build and make killer T cells, we call them, to fight off anything that we see, whether it's a bacteria or a virus. It's the same process. So when we see something for the first time, our body has to recognize it, that it's foreign. So the very first time you see something, it doesn't, and it takes a little bit longer for our bodies to say, wait a minute, I don't recognize this as being part of me, and I need to create antibodies to it to protect myself from the second time I see it again. So some of you may remember, say, even back many years ago where we didn't have a measles vaccine, for example. Measles was very easy to catch, very contagious. People would get it, but once they had it once, and once, unfortunately, they were often very sick, but once they recovered from measles, their body created antibodies and they never got measles again. That's the case for measles. There are some diseases, though, however, where we create an antibody and fight it off, but we don't hold that immunity for a lifetime. And sometimes some vaccines require booster shots. And many of you are familiar with the diphtheria booster shot, for example, that you have to have every 10 years in order to remind the body how to fight off disease. So for most of us, we don't want to actually get measles or get the disease if we can get a vaccine that provides us with a way to develop immunity without actually getting the disease in the first place. So vaccines are a way of helping our body to create antibodies or to create killer T cells without us actually getting the disease. And so that's what we want with COVID-19. None of us want to have the risk of dying from COVID if there's a way that we can develop those antibodies and protect ourselves. So next slide. So currently, we actually have two vaccines that are available in Canada. I'm sure you've heard this on the news. The one that most people are talking about is Pfizer. It was the first one that was authorized in Canada on December 9th. And the second one is Moderna. There are many other vaccines that are currently being developed. Some of them are in phase 3 trials, and some of them are currently have submitted authorizations to Health Canada for authorization. But this is what we have right now. We have these two vaccines, and they are actually both in the same family. So the interesting thing about these two vaccines, and I'm sure you've heard or seen pictures on the news right now, is that the Pfizer vaccine actually is needs to be super cooled. So it has to be kept at -70. The Moderna vaccine is more a traditional freezer vaccine, so it has to be kept at -20. So that's not how our normal vaccines work. Most vaccines that we have when you go to your family doctor's office, most of those vaccines are fridge vaccines. So these two vaccines have different storage requirements. And as MPP Schreiner indicated, in Guelph, we actually went ahead months ago, actually, and we purchased the special freezers that Pfizer vaccine requires. We have two of them. We can store actually up to 200,000 doses of the Pfizer vaccine. Believe me, we don't have anywhere near 200,000 doses, but we're getting ready. And we've deployed them in two different locations within Wellington, Dufferin, Guelph, in order to be able to store this particular unique vaccine, because you need to have special storage and monitoring to do so. The Moderna vaccine requires also a dedicated freezer, of which we also have that one as well for this vaccine. So next slide, please. So as I mentioned, there are different vaccine candidates, and they all work in a different kind of category. So there are 4 categories of how these COVID-19 vaccines work. And the one I'm talking about is the one right now. I'm going to talk about the one on the far right. That is the mRNA vaccines. And that's because these are the only 2 vaccines that we actually have approved in Canada. The other types of vaccines, the one on the left, the whole inactivated virus, that's sort of a more traditional type of way we produce vaccines. The protein subunit, again, is a more traditional way, and the more newest, the newest kids on the block in terms of vaccine technology are adenovirus or viral vector vaccines and mRNA vaccines. So next slide. So this is a picture, a true picture actually, of what the SARS-CoV virus looks like. And I wanted to show you this just to get you an understanding of how messenger RNA vaccines work. So if you look at this particular viral particle is actually coated with little spikes of protein. And it's important, and I've circled one, but it's important for you to realize that this is actually really important to know that this virus has these spikes, because we use these spikes to actually protect us in our vaccine technology. So if you go to the next slide. Thank you. So those little spikes, think of them actually as keys. So those little spikes attach to receptors, usually in our nose, actually. That's why it's so important that you protect your nose and you don't breathe in this virus. So in our nose or in our respiratory tract, they actually are like a little key that goes into a lock. And once that happens, the virus goes into your body, and viruses, like all viruses, need a host cell in order to reproduce. So what they do is the virus goes into our cells and uses our own body to reproduce and more viruses that it releases into the system. So that's bad, and we definitely don't want to do that. But that's actually how the virus works. So next slide, please. So how do we fight off this virus? So what happens is once we're producing virus, the body eventually it says, wait a minute, I don't recognize this cell, and I definitely don't recognize all these little spikes on the virus. And so I'm going to produce antibodies or killer T cells to those little spikes. And then what happens is that when in the future you were to come in contact with a coronavirus, it would say, yeah, I recognize those little spikes on that cell. That's not friendly, and I'm going to attack it and kill it. So that's how our body would respond when we get the coronavirus in real life, and some of you on this call may have already had the coronavirus. So your body has produced antibodies to those little spikes so that the next time your body encounters it, it will say, yes, it's foreign and I don't like this and I'm going to attack it. But we don't want to actually get COVID in order to protect ourselves. So what the vaccine does, it gives a very brief message to the body about that spike, about that little protein, to say, this little spike protein, you need to make antibodies about it. So that's why it's called a messenger RNA. It's giving a message to our bodies to say, make these little spike proteins. They're not the virus, they're just the little proteins. And then our body says, oh, we need to develop antibodies to these little spike proteins. And then that will protect us from future attacks when we see those little spike proteins. By the way, I did try and find a really simple slide to show this. I could not find a picture which really provided it in a simple language how our bodies make make antibodies to viruses. Next slide, please. So who can get the COVID-19 vaccine? So currently it's healthy adults. You have to be at least 16 years of age or older for Pfizer, or 18 years of age for Moderna. There is an ongoing trial right now looking at the age group of 12 to 15. So it is possible that by the time this is rolled out next summer more widely, that individuals 12 and up for Pfizer will be able to receive the vaccine. And for Moderna, I'm not aware currently of any child studies, but this is who. So there is no child vaccine currently available. So I also get questions about, well, what about people who maybe can't get the vaccine or who shouldn't get the vaccine? So when you do a trial, any kind of vaccine trial, there's certain groups of people that you don't actually include in your trials. And the first group is pregnant people. They don't go out looking to do the first vaccine trials in pregnancy for a lot of good reasons. Why, I'm sure you can all guess that we don't want to include pregnant women. Now, with any vaccine trial, especially when you're covering tens of thousands of people, what you do find out is that there are some women who are pregnant during the trial. And that's because they didn't know they were pregnant at the time that they got their first dose of vaccine. So almost all trials do end up having small numbers of pregnant women in the trials, but it's not usually included. Also, those who have a weak immune system from an illness, who are on specific therapies that modulate the immune system, they're not usually included in trials. And so a lot of the autoimmune conditions are also not included in trials. So when they do these trials, they do it for sort of the average population, and they do include a lot of diseases, but there's certain ones that we know are more difficult to know whether they're safe for people who have in particular immune conditions. So they remove them from the trial. What that means is if you are in one of these categories, you should, thank you. You should continue to have a conversation with your healthcare provider. It does not mean you can't get the vaccine. I want to be very clear. It doesn't mean that. But what it does mean is that you need to check with your healthcare provider to see if it's right for you. And you will be required to attest to that. Most people who are pregnant can receive the vaccine, so you just need to talk to your healthcare provider. And most rheumatologists and, for example, those who look after autoimmune conditions, or most allergists are now providing advice to patients. So if you have a specialist that you're being followed up with, it's probably a really good idea in preparation for the vaccine that you have this conversation to make sure that they know you best, they know your underlying medical condition, and they can provide you with specific advice to you. Public health clinics, which will be run in the future, we're dealing with high volumes in short periods of time, and we don't have your record and we don't know you as an individual. So we're not the best person to tell you whether you specifically should have the vaccine. If you fall into a very special group of people or have a very special, unique disease, then you might want to speak to your specialist. Next slide. So now we know who can get the vaccine, pretty much everybody, except if you're under the age of 16 right now, and some very special groups of people, severe allergies. So when can I get the vaccine? So the first thing I want to say is that for some of you who are thinking that personally I control when can you get the vaccine, I actually don't. I actually have to implement a provincial framework. I am speaking to the province. I do sit on some COVID vaccine working groups and provide advice to the government, but the government actually in their task force and cabinet makes decisions, in particular because we have a limited supply of vaccine. So right now, who is getting the vaccine? So residents of long-term care home and retirement homes are right now who are receiving the vaccine. And actually, they're the only ones that are receiving the vaccine because I ran out and I don't have any more. Prior to me giving it to long-term care retirement home residents only, I was also immunizing the workers in those environments, as well as some high-risk healthcare workers. So those who work in ICUs, emergency rooms, our COVID clinics, for example, or our COVID floors, those were all on the list. But as people have probably heard, we received no vaccine this past week and very limited supplies of vaccine for the next 2 weeks. So while our vaccine supplies are limited, right now we just finished our long-term care and retirement home residents, and we are now reserving all our existing vaccine will be for the second doses for the people who've had the first doses. Which means logically and most realistically, we will not be moving on to any new first doses until about the third week of February, assuming that I get vaccine. And as everybody has heard on the news, there's all kinds of questions about how much we'll get and when we'll get it. And I think that's fair for people to say, if you have not had a shot right now, then most likely you're going to be, when your turn comes up, it will be after the third week of February. So now that you know who's the first group that we've done, who's sort of continuing to get it right now. So we know that there are still about 700 staff in long-term care retirement homes that have not had an opportunity to receive the vaccine, and they are at the top of the list to receive that. There are other individuals who are in high-risk groups. So there are still some hospital staff in high-risk groups that have not had a chance to receive the vaccine. There are individuals, once we've done those groups, we'll be moving on to individuals in other congregate settings. And by that, I mean, for example, some of the, like some of our adults with disability group homes, for example, those might be on the list. So those aren't large numbers, but they are what the province sees as being very important. There's also people who receive chronic home care. So there's a list. We have the list. We know who they are. Some of those individuals are currently on the list to go into long-term care homes, for example. And those individuals are eligible, as well as Indigenous communities, because they are at higher risk of poor outcomes. One of the things I can tell you, though, is this vaccines, they're not like any other vaccine we've ever had to deliver. So in the past, we've delivered all kinds of school-based programs and flu shot programs. These vaccines can't be moved in the same way that our other vaccines can be. So I can't take vaccines and go into somebody's house. We're only allowed to move them once and move them back. So this does mean that as we try to design programs and how we try to figure out how are we going to immunize people in lots of homes when I can't move the vaccine to lots of homes. You can see that there's a challenge. Hopefully they'll figure out that the vaccine can be moved, but right now I'm not permitted to move it. So the vaccine, when it goes into a setting, has to stay there and be used in that setting. So there are challenges with this vaccine. It looks like it's going to be the vaccine we're going to get for the near future. Hopefully, if we get any other new or different vaccines, they'll be more portable. They'll be able to be distributed potentially through primary care offices or through other settings. But the Pfizer vaccine, with its specific storage requirements, its very specific handling requirements, and the fact it can't be moved, along with the similar for the Moderna vaccine, makes this not your typical vaccine rollout plan. After we've done sort of these settings, the province has indicated that in particular those over the age of 80 are likely going to be sort of the next target group, so community living over the age of 80. The province is committed to sort of doing an age-based rollout, and then looking at those maybe between the ages of 75 and 79. But they're also recognizing that there are people in the community with underlying medical conditions, as well as large numbers of interest from certain groups of essential workers that also want to get into the queue. So who goes next is not my personal decision. I want to make sure I be really clear, but one that we will implement locally. If we had lots of vaccine, this wouldn't be an issue. It'd just be, we just have to, how quickly can we get it? And if you didn't get it today, you're going to get it, in the next couple of days. When you have limited supply, I can tell you that on a daily basis, I receive letters from groups of people, not just asking to be on the list, but asking to be at the front of the queue. And all I can say is that we are trying to make decisions very ethical decisions on who gets the vaccine next. I know you've all heard of the odd person. We all know about the executive who flew up to, the Yukon to get his vaccine. And we locally, and in particular with our hospitals, have created prioritization lists. And we are trying very hard to ensure that our doses go into the homes of those, the arms of those who need it most, because we know that this is a very important program. So the next stage after this, sort of April, May will be sort of more of a risk-based approach. And following that, likely about the end of May, beginning of June, again, totally dependent on when we get vaccine, it will be sort of the for anyone approach. So if you are a healthy 40-year-old right now, I'm thinking that you're receiving your vaccine around June. If you are an individual who's over the age of 80, my guess would be that you'll receive your vaccine somewhat towards the beginning of April. But if you're asking me for really specifics, this is sort of a general framework, and the province is actively working on all of their categories right now. So next slide, please. So this is how many vaccines we've given locally, and these are all first doses. There are not second doses. We haven't started our second doses yet because we have to wait a certain number of days. Second doses will begin at the end of this coming week. And so you'll see our vaccine numbers go up, but those will all be second doses. All right, next group. Next slide, please. So we received our vaccine about 3 weeks after some other parts of the province. We did receive it earlier than other health units because we were able to sort of advocate, because we had the freezers, we had all the equipment, everything was ready to go. So we did receive our vaccine, and we were and still are actually the only health unit in the province that receives the vaccine directly. All the other health units, the vaccine is going into hospitals. So locally, since we've got the vaccine, we have actually, in a very short period of time, managed to catch up to the Ontario rate of immunizations per 100,000. And if we'd have had our vaccine this week, I'm sure we would have been above the Ontario and Canadian average, but this is where we stand. So our staff, and this is one of my staff on the right here, giving a shot to an individual in one of our first long-term care vaccine recipient, actually, up in the north part of Dufferin County. So our staff have been great. They've been working hard, weekends, very hard, trying to get this vaccine rolled out with a very uncertain vaccine, uncertain supply and delivery chain, which makes our program challenging to deliver right now. Next slide. So I'll talk a little bit about some myths and misinformation and just try to correct that before we go on to questions. So the next slide. The vaccine development and approval process was too quick. And because of that, how do we know that the vaccines are safe? Because the process was too fast. So that's the myth. Let's go on to the answer on that. So I have no doubt in my mind that this is safe, that it works, and it has met all standards. So traditionally, when you're trying to get any kind of vaccine approved, you need a lot of money and you need a lot of time, because you have to talk to people, you have to persuade them that there's a need, we need this vaccine. You need people to go through to meet with you. You often get delayed. They may think about it, they may put it on a shelf. What happened with COVID was the entire world all of a sudden realized we need vaccines. And so all of the delays were put aside. Funding was put forward to move these things through the delivery channels, and things, instead of going sequentially, now occurred in parallel. And that's the first time that's ever happened. So for the messenger RNA technology, it's been around for a very long time. What it needed to bring it to market was money and something to use it for. And COVID was the exact nidus that this particular technology, which has been known about and has been in play for more than 10 years. We've known that this is possible. We've known how to do it, but it needed money in order to put the final touches on it, to build the manufacturing that it needed to bring it to market. That all requires a lot of dollars. And if there's no reason to have a new vaccine on the market, there's no dollars for that. So you can see that with COVID, this all of a sudden, all of these things that we knew we could do are now possible. And that's why the messenger RNA in particular, being the fastest way because it actually tells the cells what to do for, to build for, to create antibodies to, is actually the fastest technology and the easiest technology to bring to market for vaccines. And I anticipate that you're going to see a lot more of messenger RNA technology in the future, in particular as they work on some of the storage and handling requirements. As we can overcome those hurdles, I think it will be the way of the future. So next slide. Messenger RNA can alter your DNA and otherwise cause harm to your body. Okay, answer. No, it can't. It can't change your RNA. It gives instructions to our cells to make a little piece of protein, to make that spike protein. So it actually doesn't ask your body to make anything that's going to give you the disease that it is trying to protect you from. It just tells your cells to make a certain spike protein, which your body then makes it the antibodies for. It doesn't enter your DNA. It doesn't change your DNA. And I like to refer to it a little bit like a Snapchat message. It tells your body what to do, and then it's gone. So your body gets the message, make spike protein, which it does, and then it's gone. The message is gone. And then the body says, oh, now we have to make antibodies to this little harmless piece of protein. And now you're immune to COVID-19. Next slide. I've already had COVID, so there's no need for the vaccine. In fact, I'm recovering, so I get the same protection as a vaccine, so there's no reason to do both. All right, the facts on this one. Well, what we do know is that everybody's immune system is a little bit different, and not everybody's immune system remembers the virus even months later. We actually have documented, not a lot, but we are documented cases of people who have been infected with COVID-19 more than once. What we don't know is how long people who've had the natural infection are immune to COVID-19. That's something that's a case of ongoing research. It is not at all a harm to you. If you have had COVID-19 and you want to get the vaccine, I encourage you to get the vaccine. We want to make sure that you don't get it again. We want to make sure that you protect everybody in your life. So if you're worried that, oh, I've had it, I can't get the vaccine, no, you can absolutely get the vaccine. In fact, in our long-term care and retirement homes now, we have had a lot of people who've had COVID-19, and they are all being vaccinated with the vaccine again to ensure that we try to protect them in a longer term way from the COVID-19. Next slide. Heard people say, once you have your vaccination, you can get back to life as normal. I've had my shot, so therefore I'm good to go. And the pandemic doesn't apply to me. So the facts are currently that you have to still continue to follow all public health measures, at least for the number of months. And I say that because, first of all, not everybody's going to have the vaccine all at once. We don't know. The vaccine is about 95% effective, but I actually don't know that you're not in that 5% of people who it's not effective for. So it's really important for everyone to get the vaccine. So we're hoping for at least 90% uptake on this vaccine. If we only have 50% uptake, then we've got lots of people who are still going to keep swapping this virus around. Remembering none of our children are going to be able to be vaccinated, at least not right away, because we don't have a vaccine for them. So we need adults, everybody that can get the vaccine, to take the vaccine. We also need people, though, to continue to do public health measures. One of the things that we know the vaccine does, it prevents death and it prevents severe disease. And for most of us, we're like, okay, if I have to get COVID, I don't want to die from it and I don't want to end up in the hospital. But what we don't know yet, it's still an ongoing piece of research, is whether it prevents me from getting it and giving it to other people. We think it does, but we need the proof of that. And the only way you're going to get the proof of that is when you get high immunization rates and we can discover what happens. So Israel being the country that currently has the highest countrywide immunization rates, we're going to get the answer to that question. And obviously we know what happens in other diseases, but as scientists, until we actually have proof of something, we don't say that something is true. So yes, even though you get the vaccine, we want you to still wear a mask. We still want you to practice all the good public health measures. And when we get very high immunization rates, I believe there will be a time when we will go back to our more normal way of functioning in society. Next question. Oh, that's it. I guess now I'm up to real questions. Thanks.
Thanks, Dr. Mercer. And Jackie from my staff is curating the questions, and she'll present them to you and to me if appropriate.
Thank you, Dr. Mercer. That was really informative. I know I learned a lot, and I've been following the news every day, so I really appreciate your presentation. Some of the questions I've kind of grouped into some of the themes around them. So I'll start with some of the questions that are around the science of the vaccine, since we just finished that part of the presentation. So some people are asking, are there any side effects of the vaccine? And if we've had anyone in your public health unit has shown any of those adverse reactions?
So yeah, there are side effects of the vaccine, but the side effects aren't really any different than what you might get with a lot of vaccines. And in fact, they're a whole lot better than the Shingrix vaccine. And I'm sure some people who are listening have had the Shingrix vaccine and they can remember they felt pretty crummy, their arm was sore. In fact, some people had a little fever, they felt pretty crummy for a day or so, but everybody says, oh, but this is way better than getting shingles, for example. So lots and lots of people get the Shingrix vaccine because they don't want to get shingles. Well, what I can tell you is that the COVID vaccine is way better than the shingles vaccine. So some people do still get a sore arm, very common, very unusual, but it is possible you might get a mild fever, you might have a few aches and pains. So yes, we have seen some very mild reactions in our area, but far better than getting COVID-19 and far better than our Shingrix vaccine. And I have not, I am the one that usually sees the adverse reactions. I haven't seen any significant reactions in our area yet.
Great, thank you. Some folks are asking, with some of the new variants coming out, do we know if the vaccine will be effective against these new variants?
That's a great question, and obviously one I don't have a firm answer on. What I can tell you is both Moderna and Pfizer believe that the UK variant that their vaccines will work against. They're not as certain about the South African or the Brazilian variant. So it's actually a really good question. So we do believe that that the UK variant will likely be covered. The good thing about mRNA vaccines, though, is that they are much easier to change the vaccine, much quicker to change the vaccine and give the body a slightly different message to make a slightly different spike protein to ensure that we get immunity. So this is an active conversation. It is still important, though. There's still other variants, meaning that the regular variant plus the hopefully not, but if the UK variant takes a hold in Ontario, those are the two that we have. So yes, get the vaccine when you have an opportunity, when you're offered it, please get immunized.
And when you receive the shot, how long does it take to take effect in your body?
Well, for what we do know is for people who, remember I said 95% of people seem to develop immunity. So for those who do go on to develop immunity, we start to see it at about the 2-week mark, and it just continues to build. So we know that at the 2-week mark, anywhere from 50 to 80% of people are already developing immunity. And by the time we get to 28 days, that number is definitely getting closer to 90% for those group of people who are going to develop immunity.
Great. And then the last one on the science is just a question around why children are not approved at this stage, and what changes about someone, an adult at 16 or 18 years old, that allow them to receive the vaccine.
Well, it's the vaccine was not studied in children, so it's not approved for children. So I'm not telling you that the vaccine is not safe for children, but when they did these trials, in an adult population. So you can't extrapolate to children. You actually have to do trials in children. So the age group that the Moderna was for 18 and up, and the Pfizer vaccine trial was for age 16 and up. So that's why we have that information, and that's why they're approved. It's really strictly to do with who they studied the vaccine in.
That makes sense. And sorry, just one more question about the doses. So some folks are wondering, will this likely be an annual vaccine that we'll need to receive, similar to the flu?
I don't know the answer to that one yet. It's certainly a great question. Most of the time, if you look at coronaviruses and what we know, because we don't have a coronavirus vaccine, so that's what the family is, a common cold. What we do know is that most viral vaccines, when we give them, we think it's probably going to be immunity for a few years, as opposed to a very short period of time like our flu shot. But I don't have the evidence to support that, but most virologists who study vaccines believe that it's going to be a little bit longer, and it could be even longer still. Maybe it'll be like our tetanus shot where we get it every 5 to 10 years. I think the important thing to note, though, is that if this virus continues to create new spike proteins, ones that the vaccine doesn't protect from, then that might be the scenario where we have to have a vaccine, is if we continue to find that there are new COVID variants that we need to protect ourselves from.
Thank you. So some questions about distribution, and we know that, as you've mentioned, the supply and the challenges around suppliers are limiting the amount of people who we can vaccinate right now, and therefore the number of distribution centers or administration centers. But to your, based off your plan or any preparations for once we do have a good supply, will there be other facilities or centers in the region where the vaccines will be administered to folks similar to, I know a lot of folks have heard about the Toronto Convention Center and sort of like mass immunization centers like that. Do you anticipate that to happen in Guelph and the region?
Yeah, so currently what is in existence, just so for people to know, is we have three sites already, and the Toronto Convention Center was designed to give 250 doses a day, which is not very much. So in our Guelph office right now, we give 500 a day in our Guelph office. In the Fergus Legacy Hospital, it is designed for 1,200 a day, and we do about 400 a day in our Orangeville office. So in public health's existing infrastructure, we have more capacity right now than that convention center did. But in saying that, there's actually lots of conversations going on with some fairly large sites, because we do need parallel processes. So public health can't do it all. I've just told you sort of what our limits are and going into homes and sort of mobile clinics. We can't do it all. So yes, this is a conversation, but it's a conversation with big players and big groups to say we need big infrastructure, not just little storefronts. And because this vaccine is not easy to store, not easy to handle, not easy to mix, there's a specific data entry requirement, a solution called COVAX that we have to use for the ministry. So these are all things that are all taken into account. And yes, there is a lot of planning right now, and there's preparation being in play, because there will be other sites, likely at this point in time, not in your doctor's office unless we get a fridge stable, an easier vaccine to distribute. Then it could potentially go into your pharmacy or doctor's office, but most likely you will see in April, May, and June larger sites where people will go to get the vaccine.
Great. And do we anticipate that folks will need some sort of doctor's note or a referral in the, as we go move into phase 2, where there's a larger group of people who can access the vaccine? Do we think that we'll have some sort of system around referring folks to get their vaccine, or is that unknown right now?
So right now that we don't have that system in play right now, so I don't think there is a booking system, and you will, if it's an age-based system, then you might be required to provide proof of age, so we don't get queue jumpers in order to ensure that we're immunizing the correct population. But when we look at in terms of if you're in a special group, then we do want people you have to give consent to this vaccine, and our clinics will not be set up to have detailed conversations for complex medical people during a mass immunization event. So what we do want is people to be prepared and be ready, and there is a consent form, but we need people to understand what that is and be prepared. So if you have a underlying medical condition, what you could do right now is, in preparation, you don't have to get your doctor to sign a consent. We're not asking for that. We're saying is for you to say, why don't you have a conversation with your healthcare provider right now? And if they say to you, oh no, don't get the vaccine, well then don't sign up for it. But if they say it's for you, we recommend that you get it, and this is what you must do, then when your time comes and we ask you the question, have you had the opportunity to talk to your healthcare provider? Do you have any questions? You can say, I've done it. I've talked to my healthcare provider. I'm attesting to that, and I'm good to go for this vaccine. And so, yeah, so that's what people can do, is just to get ready for it. But your doctor does not need to sign. a special form for you to get the vaccine, and your doctor does not need to refer you. And just for those of you who are listening, there is no waiting list. So people keep calling the doctor's offices or calling public health, can I get on the waiting list? There is no waiting list. So when you will know when the time comes that it's open for your category, and then you'll be able to book an appointment, but there's no waiting list.
Thank you. And I think we have time just for 2 more questions. So the next question is around prioritization. And again, I know that some of these questions around what the future holds sometimes feels like we're looking into a crystal ball, but to the best of the knowledge that you have, do you know if folks in large workplaces or manufacturing plants, such as Cargill, will be prioritized as a subclass or as a group within the upcoming phases of distribution?
Yeah, so I do know that this is something that the province will determine. I mean, there are some advantages to work to having conversations with large employers, just because of the ability to, sort of do a large number of people in one place. And I do agree that we've certainly seen significant outbreaks in those settings, but it won't be up to me. Like if we have lots of vaccine and we can create parallel processes, then that's absolutely on the table. Anything and everything to get it out as quickly as we can to everybody who needs it. If we have limited or scarce supply of vaccine, then the province will create a framework of which I will be obliged to follow in terms of who's next. So that really is out of my hands, but I'm hoping that we get lots of vaccine, and especially as we get into maybe May, and some of these questions just fall off the table, because we'll be able to have conversations with employers about how to meet the needs of your employees.
Thank you. And the last question I'll ask is thinking ahead to March break or any spring breaks coming up. Do you know of any public health guidelines that this isn't related to the vaccine, but just since we have a big group here, do you know of any public health guidelines that will be in place for March break or spring break?
Well, I don't control those levers, but it is my anticipation that the continued advice to not travel will be in place. So I do know that people are still continuing to travel. Remember, if you are planning to leave the country, you need to quarantine for 2 weeks, and they're getting much stricter about that. And there are pretty hefty fines if you choose to not quarantine. Plus, you need a negative COVID test when you come back. And that in itself can be a challenge depending on where you go, and just to get that paperwork done. And it is possible that you'll be COVID tested when you come back, as well as having to get on the plane with one. So I would really, really think twice if you're thinking of traveling outside of the country or even outside of the province for March break. This is probably not the year to do that. And I know a lot of you like to, but really, this is the time to stay closer to home and plan to do something local, support our local economy and our local businesses.
Thank you so much, Dr. Mercer. I'm going to pass it back to Mike, MPP Schreiner, to close this out.
So thanks, Jackie. And Dr. Mercer, thank you so much. I know your schedule is incredibly busy, and I really want to thank you for taking an hour out of your schedule today to provide, I think, some really valuable and informative information for everyone. And everyone who's joined us, thank you so much. I know there's so many questions about the vaccines and the plan, and I hope this session answered those questions for you. And I just want you to know that we're in good hands with Dr. Mercer's leadership, as I think you can see from today's presentation, and just her leadership in general through this pandemic. I'd also like to acknowledge, I believe our MP, Lloyd Longfield, joined us in the crowd. So I just want to give a shout out to Lloyd and thank him. He's been wonderful to work with through this pandemic. And those of you who did not have your questions answered, we have the chat. We'll keep track of that, and my office can get back to you with those answers. So once again, thanks everyone. Be safe, be well, stay home, and follow public health guidelines. Thank you. Bye for now.